Hello and welcome to End of Life University. This is your host, Dr. Karen Wyatt, and in this interview we're presenting options for the best care possible at the end of life. My guest for this talk is Ira Byock, MD. Dr. Byock is Director of Palliative Medicine at Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire, and a professor at the Geisel School of Medicine at Dartmouth. He has been involved in hospice and palliative care since 1978 during his residency. At that time, he helped found a hospice home care program for the indigent population served by the University Hospital and County Clinics of Fresno, California. He is a past president of the American Academy of Hospice and Palliative Medicine. During the 1990s, he was a co-founder and principal investigator for the Missoula Demonstration Project, a community-based organization in Montana dedicated to the research and transformation of end-of-life experience locally as a demonstration of what is possible nationally. From 1996 through 2006, he served as Director for Promoting Excellence in End-of-Life Care, a national grant program of the Robert Wood Johnson Foundation. Dr. Byock has authored numerous articles on the ethics and practice of hospice, palliative, and end-of-life care. His first book, Dying Well, has become a standard in the field. The 4 Things That Matter Most is used as a counseling tool widely by palliative care and hospice programs, as well as within pastoral care. His most recent book, The Best Care Possible, tackles the crisis that surrounds serious illness and dying in America and his quest to transform care through the end of life. It has been praised by the Wall Street Journal and recognized by Politico as a key issue book for the 2012 presidential campaign. Dr. Byock has been the recipient of numerous awards, most recently the Community Leadership Award from the American Academy of Hospice and Palliative Medicine and the Compassion in Action Award from Santa Clara University. He has been a featured guest on many national television and radio programs, including NPR, 60 Minutes, Fox and Friends, and the NewsHour on PBS. Dr. Ira Byock, I am so very happy to welcome you here today and want to thank you so much for being part of this conversation.
Well, thank you very much for having me. I've been looking forward to it.
Well, I was hoping we could begin by having you define for our listeners what is palliative care, because some of them may not have heard the term before, and also how does palliative care differ from hospice?
You know, I get asked this question a lot. Palliative care refers to a team approach of different professionals, interdisciplinary team approach that addresses the well-being of patients with serious illness and their families. It addresses physical issues of pain and other symptom management, but also the emotional, social, and spiritual issues that living with a serious illness often challenges people with. And, you know, when one person gets a diagnosis, it's inevitable that a family shares in the illness. So, you know, palliative care is this team approach of physicians, nurses, social workers, chaplains, many others, to address those myriad needs of patients and families. The difference between palliative care and hospice is an evolving question. In fact, hospice is where palliative care as a discipline was incubated in the United States. But hospice is one delivery model of palliative care and has traditionally in the United States focused mostly on care of people in their homes, in large measure, and care of people who are acknowledge that they are dying and reluctantly accept that their life expectancy is in general 6 months or less. Those limitations, by the way, are imposed by a healthcare reimbursement system, by Medicare chiefly, but also by other insurers that have basically imposed this choice on patients and families of, you know, you can fight the disease and hope for cure or living longer through treatments, or if you're ready to accept that you're dying, you can get hospice care for about 6 months or less. And what we've seen is that because of that choice, people haven't gotten the benefits of hospice care for nearly as long as they need and deserve, and their families deserve. In a sense, palliative care has been a way of working around those reimbursement structures to provide the expertise, the clinical expertise, and hopefully we'll talk about some of that, and the team-based model of care for people and their families earlier in the course of a disease trajectory when they legitimately are still indeed using all disease treatments to, quote-unquote, fight the disease and hopefully live longer. And, in palliative care, thankfully, we don't have to impose that choice on individuals.
And so it seems to me that palliative care is providing a bridge between the treatment phase of an illness and hospice, where sometimes, in my experience at least, it seems like there was a gap between patients in treatment and having to make a leap to hospice was sometimes a very big decision for a patient to make, to discontinue treatment and go to hospice. That palliative care is more of a bridge that allows the patient to still receive comfort care and have a focus on other issues in addition to the treatment without having to terminate all treatment for the illness that they have.
Yes, in short, it can be a bridge. I think it's, from my perspective, who was it? Confucius, who said, wisdom begins by naming things properly, by calling things by their proper names. And I've tried in the book, that The Best Care Possible, to in fact use that phrase because I think it is in our highly diverse culture and society, it's the one thing I can say with confidence every single person wants. When they or a loved one are seriously ill, when their lives are threatened, they want the best care possible. Mm-hmm. And in fact, they deserve it. Now, what that means, what that phrase means is for the individual to provide meaning to provide specificity for. We're right down, Karen, at the very core of what separates science from medicine. Mm-hmm. The best histology and pathology and physiology and pharmacology does not become medicine until it is applied in a specific way for the well-being of a person. In a sense, what palliative care does is help some of these overly disease-focused disciplines, frankly, that's a value judgment on my part, but I would defend it, of cardiology and critical care and oncology and even hospital medicine, and complements the very good diagnostics and therapeutics that they represent with very good whole-person care for the patient and family. I talk a lot about something called shared decision-making.
Yes, I was going to bring that up.
To me, that's the stock of what palliative care does, and really helps people define in their own terms what the best care possible is for them. It used to be when I was growing up. I don't know how old you are, but I'm 62, and when I was growing up in the 1960s, 50s and 60s, shared decision making happened when the doctor decided to share his decisions with you, right?
Yes.
But we live in more enlightened times, and for me, as I practice it and as I teach other physicians in training, shared decision making starts with understanding the values, preferences, and priorities of the people you're serving, of the person who is the patient, and then bringing the best science, the best diagnostics and therapeutics, applying that in a very specific fashion determined in conversation with the person and his or her family. Mm-hmm. That's the essence of quality, frankly, in healthcare today. Frankly, that's how the Institute of Medicine defines quality. I think, what palliative care is doing, and it's in one sense revolutionary, and in another sense nothing special, is to try to routinize that process of of highly personalized decision-making and care for people getting, state-of-the-art disease treatments today.
And in my mind, it's actually the way care should be delivered in every discipline for complex illnesses. It makes sense. It seems to be the most efficient and effective care that could possibly be delivered.
So exactly, and I think I was trained initially as a family physician, and my worldview, in a sense, certainly my clinical worldview, but actually my sort of sociological worldview has always been as a family doc. I see people as whole persons. I see life cycles of individuals and families, and see people living in community systems and social settings. In that sense, the best care possible is, of course, what we've all wanted to do, what I thought I was doing as a family doc. Part of why I said, this is either revolutionary or nothing special, is that in our, let me step back and say, in America, we don't have a health care system as much as a disease treatment system.
Yes.
We have a highly honed medical insurance industrial complex that can screen, diagnose, and treat disease. And that may sound more cynical than I mean it, because I'm glad to live in a country that has all of that technology available. But again, it doesn't become good medical care until it's applied in a fashion that conforms or that reflects the sort of conversations that family doctors have with their patients, right?
Yeah.
That really turns on what's best for you. You're more than just a disease. You're more than, your liver or the spots on your lung, or, this is about you. And as you know, Karen, because we're mortal, it's not always true that more disease treatment is better care for individuals. Sometimes it makes things worse.
Definitely, and I'd say there's some examples of that in your book. It makes a very good point, but also that each person is an individual, and so no two patients with the same disease should receive the same treatment or have the same process at the end, and especially when that shared decision-making takes place, the treatment plan ends up being just as unique as the individual.
Exactly. I'm known as a hospice and palliative care doctor, and proud to be. And I love modern medicine and disease treatment. I love it when we save people's lives from things that a decade ago or sometimes just a few years ago would have killed them. And I don't feel real tension here between cutting-edge disease treatments and giving the best care through the end of life. Not just at the end of life, but right on through the end of life. In a sense, we want to provide palliative care and hospice to everyone. But frankly, I wrote that book, and I think the discussion, we all ought to have is how do we do something far more bold and audacious, which is really transform America's health system and, frankly, social and cultural milieu so that we can give the best care possible to every person. The challenge, I think, is that you and I know it's possible to do with individuals. You've written poignant stories about just exactly that, and I've tried to do the same. The challenge as a society, frankly, let me speak, as a boomer, the challenge for my generation is to bring these success stories to scale, to make them, to routinize highly personalized care that offers the best diagnostics and disease treatments, but in no way retreats from addressing the rich, intensely personal experience of illness, the sad, soulful, often tragic, as well as the rich and enriching personal and family times that illness represents. That's our challenge.
Yes. And what would you say, for our listeners, what can the average person do on their own part to help change the way care is delivered? Do they have any power? Can they make a difference or help change this process?
I think, frankly, first and most important, take care of yourselves and the people you love. I wish I could call for all of us to join a certain organization or send our $10 to a social movement that's doing this. And frankly, I haven't seen that leadership. To be brutally honest, I wish it was there, but I haven't seen it. But I think that all of us, as citizens and, pardon the expression, consumers of healthcare, if we really, if people were to know what's possible, if they were to read your book, and to know what we know about what's possible in terms of quality, and then they firmly and knowledgeably advocate for themselves or those they love, we will change the system through the mass effect of informed consumers, demanding the very best.
Mm-hmm.
That's
almost
my
needs
hope.
to be a grassroots movement of consumers stepping up and saying, "This is what we want."
Yes, and I know it's possible. I'm not sure we're going to get there, but I'm not going down without more effort. But we've done this before. We baby boomers transformed pregnancy and childbirth care.
Yeah.
Right? When we were having babies, it changed dramatically. When I was growing up, pregnancy and childbirth were treated as illnesses. They were medical problems. I was born under general anesthesia in 1951. But as we boomers began to question authority and demand only the very best for ourselves and our loved ones, we really took back pregnancy and childbirth and demanded not just the best, diagnostics and the best treatments for, screening for preeclampsia and that, and checking blood pressures and the like, and glucoses, but also taking care of, our well-being, making sure women were eating well, exercising, talking about sexuality during pregnancy, talking about planning for breastfeeding and prepared childbirth classes, Lamaze classes. This was all revolutionary in the best of ways. And frankly, medicine didn't lead this. Obstetrics certainly did not lead this revolution. There were some visionary obstetricians out there, but this was informed citizens and consumers. Women and their husbands, demanded it. I'm old enough to remember that where the established medicine worried that fathers would fall over if they came into delivery rooms, that they'd faint. Really, it is funny, but that really happened. And in pushing for it, we found out that the results of prepared childbirth are better than non-prepared childbirth for the infant, the woman, father, and all involved. We took it back. We said that the fact that medicine is necessary does not make this a medical condition or procedure fundamentally. Fundamentally, let's call it by its proper name. This is highly personal, and it requires medical excellence, but is fundamentally personal. In the province, it belongs in the province of the individuals and families, not in the province, first and foremost, of physicians. We are here to serve.
Exactly.
And I think exactly the same socio-cultural shift needs to happen as we boomers now approach the end of life. We have to take it back.
You. Absolutely, and I love that you were mentioning that prepared childbirth has a better outcome for the mother and the infant. In the same way, prepared end-of-life care, I would say, has a better outcome. And so the emphasis being on the consumer needs to become prepared and be educated and learn for him or herself what the options are and be ready for that time of life.
Right, and be prepared to work effectively with the best physicians and the best health services that you can find. You know, in really good health care, these values are not at all in tension. But if you're in a situation where you're in a healthcare system and you yourself have severe heart disease, or your mother or father has serious cancer, and you're finding that they're focusing far more on the scans and the disease markers than on the person of your loved one or yourself, then you need to really be an informed, effective advocate for yourself and those you love. But increasingly, the best health systems are making it easier to do what you and I know are achievable quality markers.
Mm-hmm. Oh, go ahead.
I'm just saying, we're having this conversation 2 days after the Institute of Medicine released a report on cancer care that really minces no words, where this Institute of Medicine panel talks about a crisis in cancer care. Mm-hmm. Now, that persists, 30 years after the beginning of palliative care and hospice. It persists after the Institute of Medicine talked in terms of a crisis in 1997, when it talked about the care that people with cancer and other people were getting through the end of life. We're really at a time where it's important that we responsibly take charge as citizens and consumers. We have a role to play. I frankly don't think it's going to get better without, both individual advocacy and collective activism.
Yes, exactly. And I think that word crisis is not overstated at all. I'm hoping that we're, the statement, it's always darkest before the dawn, that I'm hoping that the current crisis is just the last gasp before we see a big change in end-of-life care. But that remains to be seen. Well, I wanted to ask you, there was a story in your book that was particularly heartbreaking for me of a patient named Ralph who was in the hospital and you mentioned would beg you every day to let him go home. And yet he had no advance directive. He was terrified of the idea of dying, and he wanted any and every treatment available to him. And this man was so caught between a rock and a hard place, in a way, caught between what he wanted and what he feared, that he was really unable to make a decision for himself, is how I interpreted it. And I found that especially tragic for him. And
all too familiar. I chose to talk about this gentleman, Ralph. It's a pseudonym, but his situation is tragically familiar. And I understand it. This is also poignant. I am calling for advocacy and activism, but let me and I will reaffirm that. But there are no villains here. We all just love life, and we love the people in our families, and we don't want them to die. And we have all of this medical technology. It's unprecedented, the amount of medical technology available to us. And, we're trying to use it to forestall or to cure people, of course, but also to forestall death. All understandable and with the very best of intentions. However, inescapably, you have to acknowledge, everybody has to acknowledge, the Institute of Medicine certainly has made it clear, the data makes it clear that with the best of intentions, many people are dying badly, by which I mean They are dying in ways that they would never have wanted to die. They are dying in places, nearly 70% of Americans still die in facilities, either in hospitals or in nursing homes. 20% of American deaths occur in ICUs, where virtually nobody wants to be at the end of their lives. And if quality really means, as the Institute of Medicine and the Institute of Healthcare Improvement and so many other blue ribbon panels have said, if quality entails really honoring people's values, preferences, and priorities, then, boy, we really have a bit of a crisis. Ralph was a good example, and I like the guy, but he was his own worst enemy in a sense.
Exactly. That's what I wanted to point out. When we have such fear of the subject of death and dying that we can't discuss it or make decisions, we actually end up creating our own worst nightmare for ourselves.
Right. Well, because, again, while celebrating the really advances in disease treatment and organ replacement and critical care, which, again, I love and celebrate, but we have yet to make even one person immortal.
Exactly.
And that means that when it comes, that person, somebody like Ralph that basically had this sort of chronic critical illness of organ failure, multi-system organ failure, at some point, and you never know quite when till you look back, unfortunately, but more disease treatment is like pushing the person against an immovable object. And it just sort of, causes more suffering, because at some point, the burdens of the treatment really outweigh any benefit in terms of, frankly, longevity and quality of life. The really cool thing, by the way, is that, we do know that often when we can provide, palliative care concurrent with disease treatments, people actually live longer than, they tend to live longer than they would have had we not been involved.
Yes, which I think is one of the misconceptions about both palliative care and hospice, that particularly hospice, people feel that it's giving up hope and that they will die sooner if they go into hospice or palliative care, and that really has not been borne out in the studies. That's
right. It's ironic in one sense, and yet, again, to those of us who do clinical care, it's not really that mysterious. If you're paying attention to people's pain and their, breathing and their elimination, and you're helping them sleep and helping them get around and helping them eat a little bit better, and helping them, with often difficult medication regimens, it's not really shocking that they feel a little better, eat a little better, and live a little longer. And in fact, frankly, again, sometimes people live, since they feel a little better, they can actually hang in there with disease treatments a little longer. And, I'm thinking of a guy right now who's got a lymphoma, and his disease treatments are working, and helping him live longer, but without the help of a hospice program that's seeing him at home, frankly, he probably would just quit, and in fact, would die sooner. And so, again, the best care really resolves a lot of the tensions that we often see or feel in the current healthcare system.
Yes, absolutely. And to that point, that's one of the things I observed in hospice, that when we were taking care of the comfort of the patients and really helping with the physical symptoms they were experiencing, the patients were actually free to focus more on the quality of life, which gave them even greater will to want to live longer, because suddenly they were more comfortable. So as you said, it makes total sense why this type of care does lead to longer survival rates rather than shorter rates. And another point I wanted to make from your book, you quoted a lovely quote from Terry Tempest Williams' book, Refuge. Dying doesn't cause suffering, resistance to dying does. And I think that's such a good point to make for for our society and our culture in general, that one of the things we have to get over is our resistance to the knowledge that we are mortal and we are going to die, because we're only making ourselves more miserable by resisting it.
I couldn't agree more. And that quote really crystallizes it. It really conveys a huge amount of wisdom right there. Of course, it's almost a Buddhist concept that the clinging to life that is actually what causes suffering so often at the very end of life. And again, in today's environment, there are always burdens that the treatments bring with them. I think the challenge, and this is why bending back to shared decision-making, it's so important, is that it's a highly individualized decision how much a person wants to push through and tolerate, the burdens of an illness, the burdens of different comorbid conditions, and the burdens of the disease treatments. And when it's time to really begin to let go and rebalance, at very least, focusing more on quality than quantity, more on, well-being than disease treatment. And that's a very delicate balance. I usually talk to people about this with my hands in the air, sort of, and seeing a balance scale in my mind's eye. And it's highly personalized. Mm-hmm. But our job, if this sounds too complex to our listeners, let me say that our job, my job, our team's, palliative care team's jobs, is in fact to do that, have that conversation day in and day out with people, so that as we go through that balance with our hands in the air, we can really help them wrestle with and determine for themselves what the best balance is, and take care of all of their needs while making appropriate use of the science.
And one thing your book makes clear through the stories that you present is that decision-making is an evolving process also that changes as you go along. And so because the patient's condition might change or new factors arise that have to be considered. So there isn't really it isn't that you sit down one day and you make the decision and it's done. That in many cases it involves multiple discussions and conversations, and the process evolves over time.
Absolutely, because again, as you know, and everybody I hope is beginning to learn in our generation, is that this is highly personal. This is part of life. It's not like you can do an advance directive or have a meeting with your cardiologist and oncologist and determine a plan of care, and that's that. Mm-hmm. It turns out that illness is a part of life, and things evolve and change. And very appropriately, one needs to continue to revisit plans of care as people age, frankly, but as their life changes. As people, as our spouses, get ill or die or develop, dementia, or as our condition worsens and we lose, our own precious faculties, and may want to rebalance how much we, lean toward disease treatments and away from, accepting of death, and begin as frailty and the waning of life happens naturally through age or comorbid conditions. We may want to rebalance and begin to refocus on quality rather than quantity. That's normal. Mm-hmm. That's good care. And again, I say this with stridence because we know it's not happening in a routinized fashion today. We all know of colleagues in family practice and internal medicine and certainly in oncology and cardiology and palliative care that are doing this work. But it's not routinized, and frankly, even recent studies show that these really values of healthcare are being honored in the breach. It's not right. It needs to change. And frankly, as a baby boomer, I'm really in the waning years of my own career. It's really time to turn this around for our children. I'm less worried about suffering myself as seeing my children suffering, my suffering in their eyes, or the suffering I cause them in their eyes. I want to fix this health system so that all of us are having better personal times through the inevitable end of our lives.
Well, one issue that I'm aware of is just the lack of training in medical schools for medical students and residents in end-of-life care. I see that as still a problem that I don't know. You're involved in medical education, so you may have a better feel for it than I do. Is it changing? Is there a trend to provide better education for doctors?
There is unquestionably a trend to provide better education in palliative and hospice and end-of-life care. It is, however, frankly, currently far too little proportionally to the breadth of the problem that we face. I frankly think that we have a public health crisis that surrounds the way we die in America today. And American medical education is not adequately proportioned to address that crisis, and not really for all of the improvements, and there are significant measurable improvements. They are late, but they are far too little. They are still far too little. So I think it's a mixed bag. I think, we are making progress, and I read lots of articles and hear people speak at conferences about the progress being made in hospice and palliative care. It's real. There's great progress to celebrate, but there are countervailing forces and other demographic trends and market trends and healthcare trends that are really limiting the impact in terms of measurable improvements and outcomes that we're able to achieve. And so, again, we need citizens and consumers to get educated. And frankly, all I want for people is to demand the best care for themselves and those they love, and to just know what that is and how to get it.
And to bring it back to the consumer, you were mentioning if a patient finds they're working with a clinician who's more focused on numbers and technology and test results, that might be a red flag to say, maybe this isn't the best care possible. Maybe I should, what could a patient do in that kind of scenario?
Well, so several things. First is if you have a serious illness, right? You have quite advanced congestive heart failure with a low ejection fraction, for instance, of 20% or so, or you have cancer that is stage 4, so-called, or otherwise incurable types of cancer, like non-small cell lung cancer or pancreatic cancer or a glioblastoma. Ask for a palliative care consult. If the specialist that you're sitting with says, worry, or we don't have that here, that's when I would think about going somewhere else, or saying, well, I read this book, or I heard these two doctors talking on the radio, and they say that the best care involves the best disease treatment and this, state-of-the-art team-based approach to my well-being, my comfort and quality of life, my nutrition and sleep and emotional, social, even spiritual well-being, my family's well-being. And if that can't be provided at your medical center or cancer center, think about, what your alternatives might be. Mm-hmm. Even if you like the doctor you are meeting, if you're meeting somebody for the first time and physician for the first time, and you're getting news of a serious life-threatening diagnosis, it's normal and not in any way a judgment or condemnation of the physician you're seeing to also get a second opinion elsewhere. I absolutely welcome them, and that it's just no longer in any way a judgment of the first doctor you see. This is your life, you know. It's okay to get different opinions and see and become expert in your own particular condition. So those are two things that I advise people frequently.
So consumers really do have to advocate for themselves. They have to be prepared. They have to be watching for signs that maybe this isn't the best care possible. They should read your book so that they have, or all of your books, so that they have an understanding of what is the best care. What should that consist of in order to recognize when it's not happening? Exactly.
This, you know, everybody has been reading about healthcare reform and hearing about, you know, the controversies in Obamacare and people talking about the problems and crisis that American healthcare is going through. Well, this is one of the places where it really is felt on a very, you know, in-your-face personal level. It's, you know, there are some really excellent health systems that provide highly personalized, coordinated care, that talk with people, make sure they understand what their options are, and plan ahead and do crisis prevention and early crisis management, and really do the sort of care that we hold up as the best. But we know they are the exception. And in American healthcare today, there's a lot of turmoil. There's a lot of turbulence. And you've got to take care of yourself. You can't entirely trust or turn over the care of yourself or someone you love to even the most well-meaning and skillful health system. Stay involved and retain final responsibility.
And so that shared decision making should be a value that you're watching for right up front, and that should be present in every step along the way. That there's a process for sharing in all the decisions that are made.
That's right. Yes. Now you can delegate that responsibility. If you're somebody who just is squeamish talking about these things, delegate it to a spouse or your brother or sister or an adult child who's good at this, who has some clinical training perhaps, or, you know, has interest in this, and can sort of act as a go-between and support you without you having to talk to the doctors all the time about these things. But somebody needs to be representing you in this in a way that is, you know, reflects your values, preferences, and priorities. Mm-hmm. It can be done, you know, and from my perspective, shared decision making really is the mark of an excellent physician and health system these days.
And that should be a value that baby boomers embrace. That's if anything, baby boomers are about making their voice heard and their opinions heard and making their own choices and decisions. So I think that should resonate really well with baby boomers to say, yes, that's what I want from my healthcare provider and system.
Yes, I certainly should. You know, this is really in each of our own lives, in the lives of ourselves, of course, but in our families' lives, this is really the most important issue we face. Without hyperbole, this is really as core as it is, and this is what it means to be human, as you again so eloquently write about, Karen. You know, and it just so happens that collectively, as a generation, this is the most important work we have to do. At the moment in which we're holding the torch for civilization, in a sense, we have to say it matters how we care for people through the end of life. We don't want to ration good health care. We don't want to embrace assisted suicide and euthanasia, for heaven's sakes. We want to give people the best care possible, living fully, richly, joyfully, as mortal human beings, you know, living fully through the end of life. That's the great challenge and opportunity we have at this point in human history my generation. And I think, healthcare reform is one part of it. Palliative care and hospice is one part of it. But I think much like we did with birthing, pregnancy and childbirth, we have a chance to really reframe in a very healthy, responsible way this transition from a vigorous life through illness, through death and grief, for others who will follow us to learn from and build upon. That's I think our my generation's challenge and opportunity.
That's just a beautiful clarion call and validates my intention for this interview series is simply to educate and inform people so that they can become shared decision makers and so that they can step up and demand better care at the end of life, demand the best care possible at the end of life. And I think you've stated it so beautifully. I believe it's possible. I believe we can make the changes happen.
I do too, but it won't happen without, our engagement. It's not going to happen without energy. It's not going to happen without some gumption. This is not easy, and there are vested interests in the status quo. So, we all really need to somehow re-find that mojo that we had when we were having children, and we're talking about, Lamaze classes and La Leche leagues to doctors who were looking at us suspiciously.
Going, what? What is that? Exactly.
Right.
Exactly. So this is where.
Well, thank you. Thanks for involving me in this series. It's great that you're doing it.
Well, I so appreciate your input. You have been my role model as a hospice physician from the very moment I first started in hospice, and so I've read your books and followed you, and you have just been such a great champion for hospice and palliative care, and I want to thank you for everything that you have done and all the differences you have made in the world.
Oh, Karen, that means a lot to me. Thank you very much. Thanks for saying that. That means a lot.
Yes, and thank you so much for consenting to this interview and giving your time to help educate everyone. I wanted to just mention, where can people buy your books? I want to make sure that.
Wherever fine books are sold, as they say. I really, through local bookstores, as well as through the chain stores and the internet outlets, all three books, Dying Well, The 4 Things That Matter Most, and The Best Care Possible, are all readily available. Thanks for mentioning that. We do have a website, thebestcarepossible.org, no spaces, and I invite people to come and learn more. There's a lot of work to be done. And the only way I know how to do it effectively is together. So thank you for this, Karen, and I hope our conversation has been of value for those listening.
Thank you so much. That's my hope as well. And please take care, Dr. Ira Byock, and hopefully we'll meet again someday. Thank you.
Okay. Thanks, Karen, very much.
Bye-bye.